we do this. So that's the take we have. And without further ado, we will ask from the audience, who would be willing to come be our volunteer today? And just to put it out there, so there's some safety created around what we're going to offer the experience or what it'd be like. We won't get into anything personal or be probing into anything personal. We'd have you come up, lay down if you're comfortable, run through the experience, maybe probe into some questions about really making experientially like how you're feeling about the experience in the here and now, not going into your trauma story or things like that. If you'd be willing to do that.
I volunteer, Melvin.
No. I'm telling you, I'm choosing to take video. Yeah.
You want to come up? Cool. I saw our hand first, so we'll go ahead. Appreciate
Everybody
it.
else is bachelor too.
I love that we had more than one. We were thinking we might not.
Alicia. Everyone, this is Alicia. Give her a hand.
Thanks,
That's okay. And then go ahead and get comfortable. Michael, it's so funny because Michael's the doctor, and I'm generally the one who likes to do pictures and diagrams and stuff. And Michael's like, no, I don't want any of that, right? So we say that he's more of the woo-woo one, so I'm going to give him the remote.
Oh, wow. Been waiting for this for 2 years in this relationship. Thanks.
So we're just curious, how many of you have actually interacted with the molecule?
No idea.
With ketamine on either a personal or not professional, more of like doing personal work, or maybe, how do you say when you're doing it for recreation? Recreation, what is it? Personal.
Lillie has not had experience with her.
I am not. I've only done it in terms of doing therapeutic work, I will absolutely admit. But how many of you have interacted with ketamine? Okay.
How about other psychedelics like psilocybin, MDMA, therapeutically? You don't have to say recreation. We'll keep everything above board here. Nice. Okay. Cool.
The kid of the 70s.
That's what I was saying before. This isn't, although this is new to many people, it's really not, I mean, recreation, but even as a healing modality, this was steeped in science in the 60s, 70s, and 80s, being done to treat trauma, to take psilocybin and LSD, ketamine at the time, and cultivate healing around trauma. So this is nothing new. I want you guys to have that lens too of it's newish to the world now, but this has some history. How are you feeling?
Great. Super relaxed.
Nice.
So in our office, we have either something that's on the floor like this, or I have a zero gravity chair in my office. And we offer folks like the weighted blanket. And then I'm gonna give this to you. You don't have to put it on yet. But before we get too far, do you want to go to the next slide? Yeah. The first questions we start, or that most people come up with, or that we begin to look at, are who are good candidates for this, right? And oftentimes we have different looks at what a good candidate is. For Michael and I, it's the treatment-resistant depression, PTSD, and we also like to look at, I'm also a somatic experiencing practitioner. We like to look at folks who are well-resourced. So they've done work, that they can handle being in their own inner consciousness, right? And that they could benefit from creating new neural pathways.
Yeah, so how our process works, so someone, let's say you guys have someone that you want to refer, maybe it's one of those cases. I think just from a feeling standpoint, if there's an element of stuckness in someone you're working with, is often like a way to check in on, could this be a good option? So first step is they usually interface with me. So as a psychiatrist, I'm kind of the first step in, and there's like a twofold process. So one, the more obvious is, let's make sure they're medically safe to undergo ketamine. And what does that mean? I'll give you just a couple pieces of that. The other piece, which I mean to me is equally as important, is it's the reason we have this practice together, like a really relational practice in person. We don't do evaluations over Zoom typically if that's going to be the first interface. It's a real, like, have someone come in and from the first touch point make them feel comfortable, safe, and starting to cultivate some openness, curiosity, and ability to be a little bit playful, because that's ultimately going to be what we're going to show you is how the ketamine experience plays out. That is where the healing occurs. So they're coming to meet me, and I'm looking through the lens of like, how do I create all that? Well, also like, all right, we got to get through the medical stuff, but that's pretty easy. It's pretty straightforward. And I think for you guys, maybe the most interesting or relevant would be, what are the rule outs psychiatrically? And really the only big ones to me are active substance abuse. It's being looked at, used for that, but not mainstream, and I'm not comfortable doing that at this point. But really it's going to be a history of psychosis or a history of bipolar is sort of like a legitimate manic episode. And that one's so tough for me because it's a nuanced diagnosis to me, but if someone's had a real severe manic episode, then we won't do it. Other than that, psychiatrically, for the most part, there's no rule out diagnosis. Those are the ones. Medically, I won't go through them all, but it's really, there's 5 or 6 that are there. A lot of cardiac stuff, blood pressure. Ketamine can elevate blood pressure as part of the experience. So things, strokes, history of strokes, heart problems acutely, those kind of things. I look at all of that, make sure they're good, start to get them in a good curious mode, and then next would be like, hey, great, you would make a great fit for Lillie. We have this great therapist. And get them excited. I'm like, here, let me go introduce you. Like, she's down the hall maybe, or if she's not there, I'll set them up. Then they go contact her, and the next step would be interfacing with Lillie for the intro call.
So after Michael does the main assessment work, I would have a meeting with the client and talk about what are major traumas that we might expect will come up in a CAP session. So what you're thinking could come up, or what maybe even what you're fearing will come up, right? Sort of setting the tone for what these sessions look like. So I'm likely to tell the person that this is how it goes. We also will talk about spiritual beliefs. I found it so fascinating that Bill W. actually talks about how he found spirituality by using psychedelics. And so this is oftentimes where like something higher power will come up, or a connectedness with self will come up. So talking about spiritual beliefs. We start talking about consent, so they get paperwork, but I'll also talk about different consents that happen in ketamine, and just what are your overall intentions and expectations with using this medicine. I also will contact a therapist, so we only work with folks who have a therapist already or have done long-term work. And so if Alicia had come in to me and she's been working with somebody, Eli, and she wants to do this ketamine work, I would reach out to Eli and I would ask him very similar questions. Hey, what are you expecting are going to come up in these ketamine sessions? What are you hoping might come up? Is there anything that I should know about this client? And then I'll often ask both of them, if things get challenging, what are maybe some good words that would be good for you to hear, right? So I'd say to Alicia, if you found yourself in a challenging situation, are there words that I could say that could help support you? And with Eli, same thing, which is so fascinating because we've had clients that we're automatically building rapport, but if they're in a challenging situation and under the influence of ketamine, I've said what the therapist has told me before, and it's been a beautiful process that allows for even more settling.
So I just want to name 2 terms, and then as Lillie talks, Lillie will cue you in on these terms, so you're going to hear them a lot in the community if you work with this medicine, is mindset or they call it set and setting. So what Lily's kind of talking about is, wow, what's the mindset she's creating, right? Like one of safety, one of like, wow, you talk to my therapist, like you guys support me, you guys know what's going on. I got an intention, I'm excited. Man, I like Yasinski was pretty good, but I really like Lillie. I'm feeling safe, I'm curious. That's what we call a mindset or set, so huge. Setting, obviously they're looking at, cool, what's the room like, what's the environment I'm gonna be using, etc. So as she talks and works through, I just want you to notice those two terms, because those are really the cornerstone of this process to make it whether successful or really not successful. Next flip slide.
Go for it.
Right, did you just
Yeah,
the right slide?
that's it.
Cool.
When Alicia does her first assessment with Michael, she's already started having the preparation for it. So she knows that she can't eat or drink 4 hours prior.
Yeah, 4 hours, they don't eat or drink.
So she's gonna get the whole list of things that are expected that day. Part of the mindset would be, when I meet with her, I'm telling her, hey, before you come in, let's do, some meditation. Let's not engage in anything for the days even beforehand. Don't engage in anything that is too overwhelming. So probably not the news, especially currently, right? Or being around anything that is highly triggering, like just trying to set yourself up for settling even before you get here. And then we come into the CAP session. The way this looks generally when someone comes in and we lay them out like this, the lighting this is pretty light, but it's very toned down. We use LEDs. They're in a nice, comfortable state. I'll ask people in my preparation session with them, I'll ask them to bring anything that is resourcing to them. So are there pictures? Are there stuffed animals? I have clients that'll bring in their own pillows and blankets. Is there, like knickknacks of some sort that you feel are beneficial for helping you move into the most settled state that you possibly can? And then in this session, I would generally start off, actually, Michael would start off with blood pressure.
Yeah, so they usually when they came in, first thing we get their blood pressure, that's okay. We have a cutoff. If there's above that, we don't do it. It really doesn't come up that often, but we have a cutoff. Make sure that piece is okay. And then Lillie would proceed with what she was talking about. This would be, I know I think you asked about the Christian or religious piece. We bring in spirituality if that was important to them. They've prayed, that's important. We cultivate whatever is important to someone. So it's really customized to what is going to cultivate that safety for them. The blood pressure is taken. Lillie preps them. Are we ready for first dose?
Nearly.
Okay.
So I would also, this would be spirituality stuff. If they wanted to, before they even go under the medicine, if spirituality needs to come in at or wants to come in at this point. So if you wanted to pray, or I have some folks that like to pull cards. And so if you wanted to pull cards, we could pull cards. I find it so fascinating. This is actually animal spirit cards. And people really love this deck for some reason.
They love that
I
deck,
don't know,
yeah.
it's so curious to me. And then I would ask, and you can completely make this up, okay?
Or be truthful.
You'll never know.
In terms of an intention to ask the medicine, what would you like to what would you like to find or work through in the medicine today?
Your lowering goals of
And looking at that, what would you hope to gain? What would be the thing that you would hope the medicine would show you?
clarity and peace around things and questioning the question.
Yes, okay. If you didn't hear her, Alicia Alicia said that she would like clarity around, or having peace and clarity around the abandonment that came up in her life, and she would like the medicine to give her or show her how to find that. Is that?
It's like a recurring theme that continues to show. So the clarity would be decision making around future reminders.
Decision making around future reminders. So as it shows up in her life, being more clear around it. So after she gives the intention, we've done cards, we've talked about orienting to the room, right? Just allowing more settling, there's nice music playing, then Michael would generally come in. And it's usually at this time, if you want to or if you don't want to, you can have the mask. And that just, what the mask and what the weighted blanket does is it allows for more of like internal focus.
And so I'd come in and check in, and also just the ketamine can distort vision in general, so it's also could just be distracting, not productive distracting, but just kind of a type of experience that's not super comfortable, so we let them play with that. So I'd come in, I'm in the building at all times, but I would come in when Lily's ready, enter in. She's here for the full 2-hour sessions, just for context. This is like a 2-hour process. So about 15 minutes, Lily would be prepping me to come in. I'd be like, hey, Alicia, just checking in, making sure she's ready. Anything that we can do to get you more comfortable, make those final adjustments. And then what we do is we do
Hold on 1 second, I forgot something. Ethics say in ketamine, we had Alicia sign all the forms. So in terms of that she's signing off of all the precautions with ketamine, but I also, because I'm a somatic experiencing practitioner, I have her sign off on doing SE, and then I'm also more educated or trained in somatic touch too. So part of the SC work is being able to track her system. And it would be at this point before Michael gives her any medicine, because you can't consent after that. And just to clarify where she's at on the day, I would generally say, hey Alicia, if you found yourself in a challenging place, would it be okay if I appropriately give you physical touch support? And normally what I would do that is by either touching your arm, right, or your shoulder, maybe holding your hand, or sometimes I'll help support your ankles to help allow you to feel grounded. Are you okay with that?
Absolutely.
Okay. And we also would go through the flight instructions. I do it either now or before Michael gives the ketamine. I've highlighted a few just so you can hear how it's really a beautiful setup. So every journey has a beginning, a middle, and an end. And you will come back from this journey. Approach it with beginner's mind and curiosity. Relax your critical mind so that you're not analyzing what you're experiencing, nor wondering why something is or is not coming up in the session. Trust your inner healing intelligence would not bring up more than you can effectively handle or eventually integrate. Keep moving, letting the music guide you and merge with you, and exploring and entering different spaces or terrains so that if you see a door, open it. If you see staircases, go up it. If you see planets, explore them. And if you see bodies of water, go into them. If you see windows, jump through them. You can use your breath to explore, inquire, and go deeper into experiences. You can ask me for help whenever you need, if it feels appropriate. And I'm here for physical support, grounding, anchoring, and encouraging. If you need anything, feel free to ask for it. Side note, being an SE therapist and tracking her system, in this whole process, I'll use SE and I also use IFS, so Somatic Experiencing or Internal Family Systems, because there's a lot of parts work that'll come up in CAP sessions.
So yeah, so we give, I won't go into specifics of why, but you can ask questions after if you guys get curious, but what we found super helpful is we do one initial low dose of ketamine, we do intramuscular, so they get an injection in the arm. So I'd come in and do that, it's a really low dose. We call that, it's sort of like a psycholytic dose. The term, just out of curiosity, was like a dissolution of the soul or dissolution of the psyche. Was an analyst that coined that term a long, long time ago. Now it's really just meant to be like, we're gonna give a low dose that'll relax someone, create some safety into the experience, they'll be relaxed, and it starts to, you know, loosen defenses, or Lillie can give some context of parts work language, but really you're just relaxing some of that hypercritical defense mechanism so they can just start to talk about the experience. It'll be an interactive 15 minutes is first dose, and they get about 15 minutes where they're fully interactive. So that's when Lillie would have this 15-minute window to do some interaction with them where they're still very present but just relaxed.
Go ahead if you want to put your eye mask on, because your eyes are going to get sensitive. Okay. Do you, I asked Michael, I'm like,
You don't have to try.
I'll do one with you afterwards.
Okay, it's okay.
Yeah, take your time. And just for the sake of it, Alicia, just to have a conversation, how does it feel being in this space, in this room, knowing that there's these other folks that are listening and paying attention?
You were very relaxing. You're both setting a wonderful comfort, so it's okay. Part of the thing. These things come. Thank you.
Yeah, is it okay to notice that part of you that feels okay and supported?
Absolutely.
And if we were to identify maybe how it feels internally, what do you notice?
Right now, just a sense of calm. Maybe a little bit of excitement, stuff you're learning, you're appreciating.
Yeah. Go ahead and just allow that. Notice what happens.
You guys hear? Okay, cool.
When we're in this psycholytic, this is generally the protector parts start to present themselves. So it might be like a critical part that will come up and it'll say, I don't know if I'm doing this right? Or this doesn't, I think I'm doing something wrong. Whatever the voice is, it'll start to come up. And this is where we start to have conversations about that and being able to validate that part and start to allow for some of the settling that wants to come in. So this psycholytic component is super interesting. Like I just had a client the other day who is very guarded. I've been working with him for years, and I know there's bits and pieces of information that he hasn't given me yet, but we're in this psycholytic part, and he's got a very frozen presentation. And as we're talking and having this conversation and doing some tracking, he starts to laugh, and like full facial laugh, right? And it starts to make me laugh, of course, and being able to say, hey, can you notice how you're laughing with like your whole face, right? And just this really beautiful process that starts to pull away those protectors. So we do this for about 15 minutes, lots of tracking. I'll notice if people are bracing. I'll notice if I start to see an increase in heart rate or some discomfort, which at this point I'm working with them on like, hey, can you notice that you're doing this thing and what's coming up for you, and just doing a lot of the SE work. And then we get to go to the second
The next phase.
Yes.
So we're good at time. We got a good routine down. I kind of sense when Lillie's ready, so I'll come back and try to come in quietly. So the next phase is, again, this is just how we do it. So you could have a whole 2-hour session on a couple low doses. I could come in and give another low dose. Lillie's doing some good parts work. Maybe you're targeting something like a a specific thing you want to play with therapy with, you could just do whole session just like she did there, low dose, and then she does that sometimes. What we found helpful is coming in, doing this work, and then also honoring and allowing what happens if we allow someone to then go into their own, you'll hear this term like the inner healer. Like let's accept that maybe we don't know, they know, and for whatever reason, maybe they just can't access that part of them. It's too scary. For whatever reason, there's some truth in there, some part they need to access that just isn't accessible. So a higher dose, and that can range from person to person. There's not a formula for it. There's no, you will read about equations and formulas based on height and weight. Totally irrelevant in this space, has no correlation. A lot of it's gut instinct on working with people, and especially as we get to know them. But we give them a higher dose. It's called a psychedelic dose. Again, you'll hear the term, it's an expansion of consciousness. That can mean a lot of things in this space, but in general, it will range from someone staying still interactive, but maybe they start to notice, like, oh, I'm seeing some colors. I'm feeling a little lighter. Oh, wow, it's like I'm a little more curious than usual. I feel some confidence. Like, I don't usually feel that. That could be it. That could be an experience, right? Something new. A little deeper could be like, oh, I'm having a memory, like I'm going back almost like a dream state, like when I was a child, I saw something, or I experienced like, oh wow, I saw my dad, or I went back to when I was 10, or they're still aware of self. It's like, I still know I'm Michael, but I'm like, wow, I'm 10 again, and I may or may not be able to be talking during this, but that would be what my experience looks like. That's another example. You keep going, like, again, part of it's dose, part of it's how comfortable is their system to let themselves enter these spaces. So as they get more comfortable doing this work, they can go deeper, which again, irrelevant to even the dose they're on. And then you can maybe tap into, wow, what is it like to, like, I'm not even self anymore, like I'm not even Michael anymore, I'm like some spiritual, I feel spiritual, I feel connection to God, or I'm here with God, but I don't even feel like myself. And you can just have layers of the experience. I'm just giving you an idea of the second dose can look like a lot of different things. In general, it's less interactive and more of like, let someone experience it. I give them another shot in the deltoid, and part of why we do a shot, not IV, or, because that's you hear that a lot, is aside from some of the logistics of having, poles and lights and machinery around taking away from the experience, I've found with experience one of the most important things in this space is how do you experience that fear of letting go, right? Like in someone traumatized or fear of uncertainty, how do you experience like what that's like? Part of the experience I've found is once you get the shot in the arm, you're in the experience. Like you'll hear like, oh, IVs are great because we can stop the experience, like touted as something good. But if you look through the lens of like, wow, we're doing trauma work, right? We're trying to heal. That's our lens. What's it like to, you get the shot, you trust, then you experience. And it's happening and you have to move through it. There's no stopping the experience. So we really honor this technique for more than just logistics of application. So I would give the shot, and then Lillie would have about an hour and 20 minutes left of the session and she can talk about it.
So generally what I do at this point is, as Michael gives the shot, I have a couple of minutes before they're likely to go very introspective. And so I'm just gonna reiterate some of like the flight instructions. So it would be, I would say something like, Alicia, remember that if it's challenging, lean into it. If it's positive, again, like really explore it. Know that your breath is always there. You can always lean back on your breath. And if it's too difficult staying inside, maybe you could orient to the music. And I'd also bring up whatever intention she wanted to work on in the beginning. I would just sort of reflect back on that. So in this case, it would be allow yourself to notice and clarify what are the signs of the abandonment and times in your life when it's come up. And really lean in to what it wants to do. You want to turn up the music? Hey, can you turn off the lights for a second? And if you guys want to close your eyes for a second and just see what comes up in your own mind's eye. It's usually about 40 minutes that they're under the second dose. And I can usually tell that it's starting to wear off because she's becoming more present. And it's at that point that I would cue her to just sort of notice that her faculties are starting to come back online. And just start to be curious what it feels like to come back into the world. Oh, thank you. And I would ask her as it starts to come back, just to reflect for a moment what that experience was like. Omar, you want to turn the lights back on? What came up for you? Or what did you notice in that journey? And I would be transcribing because ketamine doesn't allow you to remember a good portion of what comes up. So I'm writing down any themes that she's talking about. So when she's done with this experience, I'm gonna send the themes to both her and her therapist, and I'm gonna send her a link to the playlist that we use so that she can go back and use that to reflect on when she's journaling or sitting in quiet time, just to allow the experience to come back up. And then I'm gonna help her as she's finished telling me about what's come up for her. And would it be okay to sort of check in for just a second? What are you noticing?
Well, I think just because we're not actually in that treatment, I'm just noticing I feel very calm. Your voice is very soothing. So it's probably a kind of thing that's coming up. There are a few flashes just from my current day life, but I kind of came in.
I'm gonna ask her to do some like wiggling of her fingers and toes and start to do some slight movement, right? Just to allow herself to come back into her body more thoroughly. And then I would tell her to take her time, but as she needs to begin to, she can take her eye mask off and join the world. Notice that it's gonna be very difficult at first because ketamine will make your eyes super sensitive.
bring them some water and snacks.
Oh yeah, we keep snacks.
I come back in with water and snacks usually.
Because they didn't eat for 4 hours and they're ready to have something to eat, so we bring snacks and water.
No sugar though, Mel.
No sugar.
Yeah, I'm getting a keto snack.
There you go.
And then we make sure that they're not driving home. And there's people who will ask, like, can I drive later on? And we say, no, we prefer that you don't drive the rest of the day, right? Give them, we're gonna have like the early integration stuff, back one. We're gonna talk about how the next couple of days are really important for integration. Based off of what came up for you, what are the things that you want to practice in the next couple of days? This is like prime time for helping to reinforce the neural pathways that are opened up during the ketamine experience. Examples, I have a client who grew up in a family system that did not reinforce her being feminine. And in her ketamine experience, when the protectors move away, that sense of self, or we'll call it in psychedelic world, we call it the inner organic healer, its voice becomes more clear. And so in the self, she found that herself was very feminine. And that was an internal conflict for her. So when we come into early integration, asking the question, okay, knowing this, how can you help reinforce or be curious about that feminine self? And in her case, she really wanted to dance. So the next couple of days, as your neural pathways are more open, maybe you could be curious and start to move your body and allowing yourself to dance more and see how that feels. A guy that I just had the other day, he's really bad at routine. That's part of his issue. And so he's like, I really want to follow routines. And so we talked about what a routine would look like over the next couple of days. Just sort of setting them up that we're reinforcing these things that come up in this. And then asking them to journal, spend some quiet time, while also connecting. Because you feel really connected with the universe when you're under ketamine. At least a good portion of people do.
Anything else with integration?
Just when they leave, I'm giving Eli her themes and the importance of following up with either Eli or myself to continue that integration, because the research around this has shown that the importance to allowing the medicine to work is actually the therapeutic part.
Hey, we're at the Amen Clinic, so how obtuse would I be if I'm not bringing some brain stuff, right? So by design, it's no coincidence, I'm kind of honoring, I'm steeped in, I read, I appreciate, I have the research, I look at that, but I also give it as much time as I feel it contributes to this experience of healing, which is a little bit, right? So context, right? But this is much more than the neurobiology in my experience and what I've come to believe. Some interesting things. Let's just talk about why this works. So I think most people, when they're using that term like treatment-resistant depression, I have someone depressed, what's happening that ketamine is helping them? Most people are looking at like they feel better. It helps if they're really suicidal. It helps get them out of bed when they're depressed. And that's all true. And I think largely that initial experience for people really depressed can largely come from the complexity of neurotransmitters, right? This stuff, there is so many mechanisms, but it increases across the board all of the ones you would typically suspect. Dopamine, norepinephrine, the endogenous opiate system. We hear about glutamate and GABA. Just to show you the complexity of the interactions, there is so much going on. At the end of the day, there's neurotransmitters that increase temporarily. You feel better. It really can be life-saving. That is a huge role of what ketamine does, but it's not the lasting therapeutic role. that helps acutely with symptoms, and this would be, say, primarily the mechanism. The neurobiology for what we just did here and what integration is, you know, again, let's take what we know. Does it capture what's happening? Maybe part of it, but the best we have right now on a real simplistic level. And if you guys want, like I follow all the research stuff, so anyone who wants articles that follow this stuff on a real granular level, just email me, I'm happy to send them to you. But let's just say real broad, we're taking this concept of this default mode network. I look at that in this space as like the experience of sense of self. There's a million qualities to how we experience sense of self. It's captured neuroanatomically or biologically, I think, in what people would know as default mode network circuitry. The other piece of it, the theory of mind circuitry, is what captures like what I am experiencing, other people experiencing in this moment. So I could be sitting here and be like, man, these people like are hating this. Everyone hates this. We did a terrible job. Like that's me like analyzing with the tools I have the experience of what I'm seeing. Versus ketamine, maybe I get my own ketamine therapy and I'm like, oh Lillie, you did a great job. I'm feeling really open. And like I run the same experiment. I'm like, same people, same group. And I'm like, oh, like all you guys seem to kind of dig this and like you're curious. And what I thought was like not liking it, it's just some curiosity. And I'm kind of feeling like, oh, we did like a really good job. Like what if that was my experience? Then I take all of that back to like pair that with my own sense of self, which is also open. And you start to see how like, couldn't we experience life differently? And that's integration. Like this is what's theoretically, biologically happening with integration. Ketamine softens these circuits, whether over or underactive. You can see this on fMRI, these things start to change. We experience life differently compared to the rigidity of life we've all stressed, traumatized humans have previously experienced it. And then we get a window, like a couple weeks, window, cool. So real important to go do what Lillie's talking about. Culminating in how does a lasting change happen? So like we experience differently, and not like any lasting change, ketamine not like anytime we re-experience something new, the capability of lasting change is there. Ketamine just adds another gear of like the ability to cultivate lasting change, because when rigidity is present for, listen, I'm 44, when it's present for that long, and I'll show you an example of our journeys, we have a couple pictures, it's hard to change, even though I'm like trying new stuff. Lily's telling me like, Michael, just go like engage socially, go try this. And I try it, but it's like the experience still feels like that old experience and it just doesn't move the needle. The pathways aren't laid down like with ketamine, they're laid down much more easily. This is just one study, again, if you guys want data, let me know. This in 2023, kind of the first human look at where neural pathways really laid down, the neuroplasticity, and these areas were the two areas where it was really laid down in a group of treatment-resistant depressed patients. Just an example. Okay, so this is my experience. I'll share it briefly. So I had done a lot of my trauma, I had a lot of abandonment trauma, done a lot of work throughout my life, and I knew all the stuff. I had the insight. But I did two things. I met Lillie, who I got involved with Somatic Experiencing, which is very experiential, very similar to this. And then I got involved with my own ketamine work. Wanted to just provide it to people, but to do that, you go do these experiential trainings. I thought I was going to learn how to give ketamine to someone. I ended up getting like this week-long, life-changing experience, led to years of doing some work with that modality, amongst others. And I just want you to experience, like, this is how I show people without saying any words, how I experience the world, and then the before and after. So this to me is my office where I practiced before 3 years ago. Same human, but that was such a good representation of how I experience life. Like that would represent just a good way of my internal lens of like what I saw. And this is my current office. It looks like a hybrid kindergarten, jungle gym, kindergarten, play school. It's like a playful, colorful, but that's how I experience life too. Open. It's not just, open. So this is to me what captures my work with this substance in this way, coupled with, you know, the other stuff I did my whole life to bring me to that point. Lillie's journey. Oh, this is Lillie's journey. Wasn't as successful as she's in gray.
Here, I actually do have a picture. I don't know why it didn't come out, but I can show you because it's absolutely beautiful. So when I went under the medicine, I felt like I was molding into the ground, and at first I felt the fear of being absorbed, and then I realized that my self-voice was telling me, you're okay, it's okay, lean in, you don't have to control, right? And then when I heard that voice, the thought came in for me, the thought came in for me that, oh, that's what you do for all your clients, right? And then I thought, wow, that's me. I haven't been doing that for myself. That's my voice, that's myself. And then I felt so connected with Mother Nature and found this like this power. This is not I did not paint this. I wish I had this much amount of creativity, but instead, Michael, who was convincing me to do this the whole time, he, of course, called me up after my first journey, and he's like, how'd it go? And I explained this to him, and he went out and found the painting for me. Questions?
Sure. What about troches versus the shots?
Yeah, I don't use them just because we have the ability to do the, I think the IM's just easier and a better experience. And it's just it's more predictable dosing wise, it's absorbed more predictably, it lasts predictably longer. So I just would want a preference, I think. But troches are great if you don't have access to obviously someone in the office to do it.
Awesome.
The 2-hour sessions are $700.
And how many do you recommend?
We do 6 once a week. It's kind of a good pace we found, as it gives that time, the integration time. I think you'll see a lot of, they'll refer to protocols that were done, IV protocols for depression and more traditional lens science articles, and they'll recommend 6, 3 a week is kind of the thing. I found that's just too much. You can't integrate these experiences every 2 days. It's just too much. Sometimes we skip a week, but a good ballpark 6 sessions once a week is a good starting place.
Reassess, depending on the person.
Side effects.
Yeah, really coming out, some nausea and an upset stomach, that kind of stuff is really the main thing. People will go home. Once they leave here, you're pretty clear. You feel a little bit woozy, but you go home, you eat. The next day, most people feel fine. If a lot of stuff comes up, depending on how tapped they are they into the somatic self, you can have all sorts of things that will come up more based on their specific human experience, so it doesn't really generalize as much. But the one thing that does generalize, you just get a little bit of nausea. It's not uncommon.
Two questions. One, do you have you had experiences of patients purging while they are in that non-ordinary state?
Like vomiting?
Mm-hmm.
Yeah. It's pretty common.
And the other one, I have been told that if a patient is taking benzodiazepines, that's a contraindication to the benefits of ketamine.
Yeah, that's where I've not found. So you'll see there's certain things, certain medicines that they'll call them contraindications. I found I work with all of those and have not found them to be a problem. I have people continue those. I don't find they skip those, or I don't have them skip a dose. I've not had a problem having this exact experience many times with people on benzodiazepines are common. You'll see lamictal, you'll see gabapentin is one is not to take during. And again, I see that more. You see that often in the research literature. looking at it through the lens of mechanistically reductionist, this mechanism is doing this, and so this is interfering with this. Experientially, I found absolutely no problem working with people on benzos, creating the same experience. Yes.
So earlier you were saying, try to avoid triggers for several days beforehand. What if the person is living with a trigger in a relationship or a parent? How do you deal with that?
I think it's really interesting. I think that we're less inclined if it's like an unsafe circumstance because, like for example, when I did a journey, I went out to eat with my family afterward and felt very vulnerable. So I don't know that I would feel comfortable having someone be this vulnerable and go home to an unsafe environment.
I have two questions. One, is this what they would consider an ayahuasca journey?
Ayahuasca is its own molecule, so that an ayahuasca is its own like psilocybin or LSD. It's like a separate molecule, so it would be a different substance.
And then how much therapy beforehand would somebody need?
I think it all depends. Truthfully, some people are really well resourced. I found folks who have navigated or found adaptations or created some sort of really good resourcing for themselves.
Oh, okay.
And if they have a therapist, I'm all in, right? I just want that integration piece. So if they're well resourced naturally, I think it's good to go. But I like them to have a therapist to follow up with.
I have so many questions, but I'll start with one. So one of your guys' red flags was active substance abuse. Is there an ideal amount of time for someone to be clean? Keep in mind I work at a treatment center, which is why I'm asking.
I go with we're right now 6 months.
Okay.
Is like the first line of defense of like let's just screen 6 months is good, and then the nuance of that's not always enough, but then that's a good starting place. And then it's just we look at the nuanced individual and see if it's a good, because it's a dicey piece for sure.
If in the treatment center, so I came from the Meadows way back when, and if they were in treatment and so they were in a protected, stable environment, I know that there are some centers that once they're stable, towards further into their treatment, that they've been using CAP and finding really big benefits. And if you want to know more, find me afterwards and I'll be happy to share.
And please email us or call, you'll get our contact. We love interacting, so science, therapy stuff, our experience stuff, please call us up. Happy to hop on the phone and stuff too, or email that people.
I have a non-clinical background, okay? So a lot of these names of drugs and whatnot fly over my head.
Sure.
But I did spend 8 years on the board of dental examiners and dealt with a lot of complaints and issues and things of that nature. So I have some medical questions, and then I'm going to be devil's advocate later on.
Sure.
Not to offend anybody.
Beautiful.
But the first question I have is, do you monitor blood pressure, pulse, O2 levels, body temperatures during this, I'm gonna use it, trip?
Yeah, so we just do the blood pressure before. We don't have them on continuous monitor.
Nothing during the whole process?
Nothing
So
during.
you have no idea from a medical standpoint where this person stands physiologically?
Yeah, the only thing is we'll do, if someone has any kind of sleep apnea or coming in, we'll obviously do O2 for that. It hasn't come up yet. I don't do blood pressure for the journey.
What type of emergency equipment do you have in case someone crashes?
We have suction.
Okay.
It's the only thing if you have secretions.
No O2 bottles, you have a...
I've been thinking about oxygen. I haven't historically had oxygen. I've been thinking about getting oxygen, and an AED is...
a defibrillator at all, or anything like that?
Yeah, we're getting a defibrillator.
Getting.
Yeah.
Does anyone come in and check this? I mean, in our dental offices that I own, we had OSHA come through, there's a checklist, and I had a lot of issues where we had to deal with patients who crashed and then since went to the next realm, you know what I mean? And I'm just kind of curious what type of safeguards you have, because I don't know how long this, I'm gonna use the term loosely, technology's been around.
Right.
I'm a child of the 70s, so, you know, a lot of that self-experimentation back then. Some of my friends never made it to this age, so that's what I'm kind of curious.
I think that a major thing is that it doesn't go to the anesthetic level. So I'm sure we don't get to the same place at all to where you've been.
Okay.
I'm sat in the session the whole time and tracking. And I think that there's a huge benefit that Michael is right outside the door. So I feel way more comfortable having an MD in the space with me.
Okay.
And then we reap the benefits of the fact that Scottsdale Shea is like a mile from our office too.
Well,
I
hopefully
think
my
that-
comments and concerns will bring that level of safety up a little bit.
Yeah, for sure. No, it's that balance between the safety and the experience, right? And you always have to err on, like, it has to be safe. And that's where the IV, they get continuous monitoring. With the shot or the trochee, the standard of care out there is not to monitor that continuously. With an IV, you're finding that is something that's
Sure.
monitored continuously. It's partly why we don't do IV, is for some of those things. But yeah, they're all good questions.
Thank you.
What about follow-up? Do people come back after tune-ups, or how does that work?
Go ahead.
It'll often be extended out, so we'll go through the 6 weeks per se, and we've had folks who they are indicating that the 7th week is still important, so the week after. But a good portion of people then will give them an opportunity. They know what it feels like to feel more settled after 6 sessions, or after 2 sessions, really, because you do feel this settling that comes in. And so when they feel like it's time for a tune-up, then we're available to do that. So people will generally extend out. The folks we've been working with will go from 6 weeks to, say, every other week, to once a month, to 6 months, so we can work with them depending on what's coming up for them.
I had a question. I'm wondering, as clinicians, how can we best help prepare our clients, to send them your way?
Yeah, resourcing. I think the best way of saying this is, when you're in that difficult situation, in SE, as you know, we try to create time and space for them to feel discomfort. It can be really uncomfortable when you feel like you're losing control, and to be able to resource someone that if they're feeling uncomfortable in whatever their trauma story is, and just having you present and allowing that to titrate naturally, because the inner organic healer, that sense of self, it will come in and it'll rescue them, right? Like there's a natural titration that takes place, but allowing that to happen, right? Like alcohol, substances are someone's ability to stop that from happening, right? They don't want to feel discomfort, so they go to some quick fix, right? So in therapy, if you can create a way for them to feel that discomfort in therapy and help them resource themselves, that is the best work for this. Truthfully, love that.
I'm sorry I missed a majority of this, but I think if I'm repeating somebody else's question, but how do you prepare somebody who's never had any kind of like mind altering type of substance? How would you go about explaining that?
Michael set me up for this question. That's so funny.
Have at it.
I'll often describe it as, have you been under anesthesia? Or, okay, yes,
Yeah.
okay. So when you go under anesthesia and immediately when they give you the med to take you under and you get that really warm feeling and then everything feels heavy, that's how I describe that. Hey, it's gonna start to feel really heavy. And if you can just lean into that, and just notice that your breath is still there and you're not alone, then I try to help explain to them what the actual physical sensation is. And a good portion of people are like, wow, like I don't feel all the aches and pains, right? Because that's what ketamine does, is it totally oftentimes shits off the feeling in all the rest of your body, right? And so you're gonna start to feel really heavy, and it's gonna feel, for some it can feel uncomfortable, but being able to just breathe through that heaviness that wants to come in.
I keep wanting to use the term like disassociating,
Yes.
but I feel like that's,
You do. Some people will totally be above themselves,
Yeah.
and they'll talk about that. Some people will feel like they don't exist. Like I frequently have people that are like touching their faces,
make sure
right?
it's still there.
Making sure they're still there. Yeah. Yeah.
I think if they haven't, like from the internal experience, if they've not used substances, that's where the somatic experiencing tools are nice, that modality, because you can cultivate a lot of like really new experience in them to explore that's different, new, both the feeling, the thoughts, the emotions, like a whole experience that's brand new, that you can work with them pretty quickly, and that's gonna be like a decent proxy for another brand new experience on sensory, like on different channels. So that's kind of why we like pairing these tools, one of many reasons, but that's always a go-to too. That's how I do it sometimes.
The introduction I thought was great, so. And then do you do anything like, if somebody starts to feel panicky, do you provide them with a benzo or like something that was my experience anyway. They had like first.
Yeah, I think that's another, like our general belief in how we approach this, I don't want to put words in your mouth, but how I've always approached this as I've learned more and seen, and her is part of why we package so much around the safety and her ability to even provide some of that touch piece, like some gentle support, the music. By the time they're in the journey, sometimes that, your question about purging, like oftentimes from the trauma lens, it's like what's coming up needs to complete or move through rather than continue to be stifled, right? And so again, the lens out there, you often see like, oh, IV's great because we could put some benzo in and stop an experience. I often see that as the worst thing that could happen, because that's kind of re-experiencing like what's already been happening with them. So we look at it that way. The other lens would say, sure, we could. I mean, I could do that, but I choose not to. And it's always a fruitful experience for them to navigate something really difficult with the right support. So that's how we approach it. Sure. Do you have an, yeah, go ahead.
Who's the typical patient that would use your service?
Well, since you're not a clinician, I would say just really like someone really depressed who's tried different modalities, usually a couple different medicines, and they're just like, I don't feel it's working, or in conjunction with a therapist, I've done some great work, but man, I feel stuck on, kind of like my illustration, I know differently, but I just still feels this way. I want to feel this way, I've done the work, but life still feels this way. So they're working but can't experience something new, and this experiential allows them to kind of feel something different, I think is how I look at it.
Have you ever declined treatment to somebody because in your professional opinion you don't feel it would be best for them?
Oh yeah, all the time.
Okay. And what would, just without being specific in bypassing OSHA, in what cases would you decline treatment?
Just when I see them, like they're not, this tool isn't the right tool for the job. Like they're wanting a big cathartic experience is super common. They read about ayahuasca out there and like, I need some big release of my trauma. And they come in and they're not resourced. They haven't had a foundational level of work of even understanding what their trauma is. They just want to like do something and feel better. And that's 9 out of 10 times the people I don't take on.
Do you get any legal trip seekers?
Not really for us, because we're so like referral, we're grassroots based, so we're getting people like they're known.
I mean, it's expensive. You're not going to get some junkie off the road, but
no, there's places out, like there's other places that take more. Like we're just cultivated the, like people know we kind of do it this way, so we don't get a lot of random calls for it, or we haven't thus far. That would be a pretty easy rule out. So you kind of take them in, and I think it'd be clear pretty quickly. There are places doing that. I think to me that this is a little bit of the wild, wild west out there. Why we love coming to do this for you. We started a group in town of clinicians to do it ethically and talk about these things, because people are just showing up to clinics wanting obviously to get high or do those kind of things. And I don't want this tool to go away for the people benefiting.
And how long has your clinic been in existence?
I've been doing it for 2 years. We came together to create like a co-entity 8 months ago. So.
Okay. And what makes it legal in the eyes of the federal government? Because I don't know, remember, Kesey and all those guys back in the 60s and 70s going on LSD trips and shit like that.
Well, yeah, so ketamine's the only legal one, so we work with ketamine, it's legal, just medically it is legal, it's a Schedule 3 that's legal, so we don't work with any of the other substances. Psilocybin almost passed this year, it didn't. So federally and state-wise, ketamine is legal to work with in this capacity.
My question is, a person's gonna be kind of in a zone for 40 minutes or so, going through all kinds of experiences. When they tell you what they saw, number one, do they remember? Number two, because they're coming with a bias to how they're gonna report it, how accurate do you find or inaccurate?
I don't even think it matters. I think it's the words that they can create. A lot of folks will come out of it and they'll actually just sort of label, you know, I saw these shapes, or for me it was that I felt like I was melting into the ground, and then I felt so connected with Mother Nature, and I felt so powerful, and then I realized that the voice that I was hearing was the same one I use with my clients, right? And that's my voice. And they'll often just use whatever words that they can. And I think honestly, they say what they can, because there's a few folks that they're like, I don't actually know, right? Okay, why don't you go ahead and just notice what it feels like right now coming out of this experience? And it's even, I've had challenging experiences, like I work with sex addicts, and I had a guy who had a pretty serious acting out history in his early 20s, and his challenging experience under the medicine was he recalled every time that he had acted out. And so when he came out, he was very challenged, right? But the reframe on it was, I think that the medicine showed me why I don't want to do that anymore.
Do you guys ever do like recordings of the sessions, and then in your review sessions allow them to listen if they don't, since they don't remember?
No, but if someone actually did bring that up, I would be
I think that'd
completely
be super
open for
cool,
that.
especially because they lose that part with their memory.
A good portion of people
Yeah.
really go internal though.
Yeah,
And
that's true.
they don't even want you to really talk to them when they're in their deep introspection.
Are they typically talking? No?
In psycholytic, yes. In the psychedelic, they're more, like I've had clients who want to talk, and a good portion of the time I'll oftentimes say, hey, why don't you notice what it feels like to not have to talk?
And part of that too, I find it's like most people coming in this space are really comfortable left brain insight driven, right? So the nature of not doing that is kind of part of the benefit of this process, is like having a detailed recording of everything is almost like too similar to what they're already doing. So it's like, we kind of don't want that,
And hypnosis won't provide the same
It can.
outcome
Yeah.
without drug interactions and.
It's another tool. Yeah, I can create a cultivate a similar. We have a good friend doing training in hypnosis now.
Yeah.
We share like how it cultivates very similar, access to certain material and states.
So how do you keep this as opposed to being expensive? How do you keep it from being habit forming? Let's say someone's totally out of touch with reality, because I grew up
Sure.
that drugs are for those who can't handle reality.
Yeah.
So obviously you can see what side of the fence I'm on this one.
Yeah.
So I hear this and that's great, the whole bit, obviously not for me.
Yeah.
Do your thing. But it just seems to me that, because all I hear is how you feel.
Yeah.
Well, that's all subjective. All right, I come from an analytical background.
Right.
Show me the study, show me the paper, show me where statistically and rationally there's been a change, as opposed to, oh no, I don't feel like a cat anymore.
Can I make a suggestion?
Oh, sure.
That's my son right there. Can I make a suggestion that I'm gonna have him give you a card? And I don't know if you're open, but I would love to sit you down and just take some time to, create some rapport, so that you can see what it maybe feels like without any sort of medicine, but having more of like the somatic experiencing, just to just to create like a understanding of what we're doing, because it's more than just, Michael keeps reiterating, it's not just the medicine. The biggest part of this is truthfully the therapy. If you're open.
I appreciate the offer and may not be a very good candidate for your service.
I love your tongue. I just want you to know. You're my favorite.
I'm just being honest.
And there is data. I'm happy to like give you track the article. There's lots of articles to be.
So I said I'm non-clinical, but I have, this is what I see
would
from my
love to give you some
perspective.
clinical.
And I'm sure other people probably have similar questions.
Happy to.
Richard,
happy
you
to
might
send
end up
it.
being the best candidate.
Yeah.
Well, at this stage, I just want you to go.
Yeah.
One
I'm
more
a
question.
person.
One more.
So
Then we'll close it.
on the website, so the intake is 400, ketamine 2-hour session is 700. What is the integration session?
So if you're not already one of our clients, right, for integration, like just doing integration work, it's the cost is either you're doing a session with me or you're doing a session with Michael.
Like an extra therapy session and
So
integration
works.
material.
But I thought you require people to have therapies.
Yes,
So-
unless you've done extra work and you're in that part in your process.
Okay.
And so another integration, because we want to do integration sessions with you. And if you're not able to get in with me, Michael's being generous about putting the integration session for $350.
Well, let me just thank Lillie for your time. In the interest of time, we always like to go around the room and share what services you offer to the community. Obviously, we want to get you going and be respectful of your time. But Janice, do you want to start off and
Sure.
share what you offer?
Yeah, so I actually, in one of the services that my clinic offers is Irlen syndrome screening. Anybody heard of that? Probably not. Oh, good. So I love all the brain history because Dr. Irlen has done over 200 scans of people that have it. It's a visual processing disorder that affects your ability to read. It can cause read and have migraines and affected by light. People that have it usually commonly have ADHD, brain injury, learning problems. If you have difficulty reading, 50% of the people have Irlen syndrome. So if you have family members or friends that have kids that have difficulty reading, they can't help them. They might have Irlen syndrome. But the brain is activated in the amygdala and in the visual centers. So people that have it are also depressed and have anxiety, and they have difficulty initiating and wanting to engage in visual activities. So screen time and TV. So and anyway, once they have the treatment, which is, I do the screening and I give them overlays. The treatment is to have very specialized lenses put on their glasses if they don't wear glasses, and they give them to them. The brain actually calms down in the amygdala and increases in the verbal areas. So verbal and non-verbal is actually improved. So anyway, I have some, if you think you know somebody that might have it, I have like a short little screen that you can give that family member. I do it because it's highly effective. I'm an occupational therapist and I found out about this and I continue to do it because it's so highly effective.
Thanks, Janice. Shelley.
I'm Shelley Pospihala. I work with Behavioral Health Connections. We're a psychiatric hospital system of UHS hospitals. We offer, by the way, Quail Run Hospital, Linda Hospital, Valley Hospital, Calvary down in Tucson, and Calvary. And so we offer, all of our hospitals are going to offer inpatient acute stabilization and intensive outpatient therapy. We offer programs for women only, treating women with postpartum depression, loss of a child, assault, any one of those things. That's a separate track. And we also have a Patriot Support Unit at the Linda Hospital that works specifically in the longer stays. Typically the inpatient stays will be 3 to 8 days. It's just to get them stable, but the Patriot Support Unit will keep them for 20, 30 days to help that particular population's process what they've been through in their service, or other things. We also all do detox of some variety. Valley Hospital does 18 and above. They're a smoking hospital and they have a fantastic, longer-based detox center there. And Quailman Hospital has, coincidentally, a program that is for geriatric patients, dementia patients, combative dementia patients. Dr. Shu runs that program. He's run it for a long time. He's excellent does there.
I'm Heather with Canyon Vistas. Dana, she's also with Canyon
Me
Vista.
Did I meet you?
Drug and alcohol, residential in Mesa, Arizona, in alcohol commercial, and 8% for detox only. What she said.
Kimara Vaughn, I'm a psychiatric nurse practitioner and a naturopathic physician. I have private practice down that way somewhere, and I do acupuncture, at-home ketamine, and herbal medicine. A little bit of bunch of love stuff.
Acupuncture. It's good stuff.
Yeah, I like to play darts.
Charles Jackson, non-clinical background, as you all know. I work with Agnes Chow with the Empowered Heart, where she helps program your subconscious. And I have a certificate in common sense.
Glad you made it.
Thanks for being here.
Charles, come find me.
I'm not lost.
Holly.
Holly, well, I'm not lost. People don't think I have common sense, but I really do. I'm a professor and I'm teaching this stuff.
Hey.
And I want to teach it to little kids that are smaller than me.
There you go. Jade?
Yes, my name is Jane Reynolds. I'm board certified in holistic nutrition and certified as a nutrition recovery coach, and through Avon Clinics as a brain health professional. I do nutrition and lifestyle changes to support better mental health, especially anxiety and depression.
Oh, I love that. My other passion, nutrition.
Yeah.
My name is Adam Guy. I'm a registered nurse. Currently work at Oasis Behavioral Health in Chandler. We have adolescent psych and behavioral, and also adult psych and acute detox programs.
My name is Abby Guy. I'm currently affiliated with Christian Counseling Services. Jen is actually my boss. So I'm currently an intern, finishing out my internship and transitioning into a licensed associate counselor. At Christian Counseling Services, we focus on trauma. We are all EMDR therapist trained, and we really integrate the spirituality, our faith background, and also with that EMDR trauma.
And so I founded Christian Counseling Services 24 years ago, and we've got 32 locations all over the state. We also teach and train interns and therapists who want to learn that integration of Christian spirituality and professional psychology. So that's what we do, and I'm an EMDR Institute facilitator. We love IFS, do a lot of integration with EMDR and IFS, and we're starting to move into ketamine, especially because we simply have some people we cannot help. Done everything, pulled everything out of our bag of tricks, and we cannot help them. And so I'm real intrigued for this, for that population.
How was this for you, Jen?
Fabulous. Loved it.
And thanks for letting us give you guys an experience.
If anyone hasn't been to Avon Clinics before, our clinic is just next door. More than happy to give you a little tour around before you leave.
Yes, beautiful. Looking forward to meeting you. Yeah.
He's scared to death to go down there because he's going to get around himself.
Yeah.
He's scared.
Well, if we, when's he going? Yeah, I mean, he can give me a call if he wants to like just chat before, whatever. Happy to support. Yeah, totally.
No, Carlos is my life partner. The business guy. So she has a family business. She manages the market. I'm sorry.
So, I think nice to meet
That's just my opinion.
What's that?
They're in the mail.
any ways to like use the old tools,
Write down your
get find enough data.
Do you go to
Yeah.
I just never, I don't get out much.
Oh, you can keep that.
I was gonna write my number in the back.
Yeah, I got you.
And Christian counseling services.
Oh, yeah, okay, okay.
Yes, there's the pen.
How do we, yeah, how do we?
Well,
that's not my last name.
Oh.
Yeah,
To do that.
I think that would be
Fire department.
The fire station is usually 5 to 5
My husband's
days.
Sessions is roughly every 6 weeks. Usually okay.
6 weeks, because what it'll do.
Best thing to do is to speak to like your mindset.
That's where it was.
Yeah.
Why would you say first responder work with the
see the molecule and you see the power points, and also where you come from. Originally, what's your Yes, very deep.
She does it over.
So bring that in,
Real time, help you do it.
Okay, bring it
Some invites over?
What's that?
I say a lot about it. So have you guys, they know it's not for doing this is like,
Do you want to come and speak to us again? Because now there are 42.
it's honestly, I just did an incident on so fascinating how
It's,
those parts will come up, and I haven't specifically had anyone who's been very apart.
Yeah.
But
Well,
I
let me
can
get in touch with you. I've got your, and I do
That's what I was thinking about.
I think
What
your
name
name
is
okay, or Perry is around with us. He's a supervisor now on the leadership team, and he's just a rock star.
I think the hard part is the resourcing for those people, right? It's like you're creating, I can see that as being a challenge, right? Like, they're inherently hard, they're not, they're often hard to resource, right? So how do you combine something where you let me resource it, you know?
Gilbert, I got still forward.
Yeah, this first time was really cool.
Okay, I'll contact you if you want to get us good. Okay, thanks,
Thank you.
Yeah.
So long that I'll tell you more after.
Yeah, we're kind of always exploring new ways to work with stuff.
Curiosity.
Nice to meet you, thanks.
It was nice to meet all of you.
See you guys. Yeah, you too. For sure, yeah, thank you guys.
I'm the weird one like that.
Let's blow this pop stand, as they used to say back in my day.
Pop.